Hello, everyone. Thanks so much for joining me this Friday, the last Friday Facebook Live of the year, actually, for us here at Reactive. If you've been joining us, we've been doing this for quite a while, every week, and this just happens to fall right at the end of 2020. Thank goodness that we're moving into a new year, right? If you haven't met me, my name is Julie. I am the owner of Reactive Therapy and Wellness here in the Los Angeles area and home of the Schmidt Movement Disorders Fellowship, which is a fellowship program specific for physical therapists who want to specialize in movement disorders. And as a part of this fellowship, we do a ton of learning and teaching and sharing what we do. And we share a lot of it in these Friday lunchtime chats here. And today we are doing one of my favorite topics. We are talking about functional movement disorders, and even more, we're talking about differential diagnosis. So, two of my favorite topics, really. If you know me from USC, I teach at the University of Southern California, really proud of that. And I teach in the course to physical therapists all about different disorders in the nervous system, and I love it. And I liken this process of differential diagnosis, of trying to understand the diagnosis, as mystery solving. So my kids have read a lot of Nancy Drew. I read them growing up, and I love how she is always finding clues to solve a mystery. And that is what we do in differential diagnosis. And I really have a lot of curiosity about this, and I have a lot of curiosity about it in functional disorders. So, this is really a match made in heaven for me to talk about these two things. And really, we bring this up because it comes up so much. And I literally had two students from USC who were on their clinicals in the last couple of weeks email or call to ask me about some patient cases and to ask how do I know if it's a functional movement disorder? And what are the differential diagnoses here? So that is exactly what we're going to talk about today. I want to start off first, though, because if you've never heard of functional movement disorder, we need to just talk about briefly what it is. A functional movement disorder is characterized by involuntary, so not voluntary, but learned movement pattern that is driven by an abnormal self-directed attention. This is a great definition that was given by Nielsen in a wonderful paper, by the way. If you're new to functional movement disorders, Glenn Nielsen, 2016, great paper for physical therapists. What is important in a functional movement disorder is that it's not due to an isolated neurologic lesion. We deal a lot of that in our typical world of you had a stroke in this particular area, but instead it's a connectivity issue. So it's the talking between those areas that's disrupted. And I actually think as our imaging and our testing get better and better, we're going to see that in the imaging. It's just not showing up there yet. Um, so it's a connectivity issue. And that abnormal self-directed attention is really important because that's how we tease it out in our testing. By the way, I just did a live video on our Instagram channel about 4 tests that you can simply do as a physical therapist or occupational therapist to screen for a functional part of a disorder. So you'll have to check that out. Um, so that's the functional movement disorder. And what has really changed in the last few years, it used to be that this was a diagnosis of exclusion. You rule everything else out, and this is like the catch all for everything else. Well, that is not the case anymore. There are positive testing and findings that can be done to rule in functional movement disorders. And it's very, very common. So I want to give you a couple of statistics here that are in a couple of articles. So um, non-epileptic, so functional seizures account for 1 in 7 patients going to the neurologist. That's very common. Functional limb weakness, so functional paralysis, is as common as multiple sclerosis. So we're seeing it for sure. If you're working in a neurology clinic, if you're working as a neuro PT or OT, you're definitely seeing it. And maybe like me, you missed it early on because I didn't always understand functional movement disorders. So you're going to see it, and you want to understand where it might be confused with other diagnoses, right? So there are some really common differential diagnoses that need to be considered. I want to go through that first. So by the way, today we're going to talk the common differential. We're going to talk about some of the simple clinical tests and then how that differential turns right into treatment today. So first, the common differential diagnosis. So number one is stroke, probably the most common. And a pretty recent study, it just came out in 2020, actually showed that in a large stroke center, 8% of those people actually had functional hemiparesis as opposed to stroke. So there can be that somebody is admitted to a stroke center for a stroke, and it might actually be functional paralysis. So imaging is the gold standard there for us to be able to distinguish those. So as physical therapists, we don't do that. And disclaimer too, I say this all of the time, but movement disorder specialists all the way. Highly recommend a movement disorder specialist to help distinguish these diagnoses. As a physical therapist, as an OT, when the person comes into us, we're going to screen and then send them to a specialist. So stroke is common. Multiple sclerosis is very common because it has this waxing and waning, maybe fatigability of the symptoms. And again, imaging and really we can do lumbar punctures. There's a lot of other things that can be done to help rule in or rule out MS. Orthostatic tremor is another one. This is something that we've been able to work with people with orthostatic tremor and help them. Alien limb, some of those posterior parietal lobe sensory disorders can look like a functional movement disorder. And again, there may be imaging and further neurologic testing that would help us understand if it's a different syndrome that is causing like an alien limb phenomena. Stiff person syndrome, another common one. Here we could I say neurologists would order electrophysiologic testing and even anti glutamic acid decarboxylase testing. So they would have positive antibodies for that. So that might have been too much information for you, but I found a little article on that and I found it really interesting. Dystonia is a common one, myasthenia gravis, but of course, we also have some blood tests and tensilon tests that could help distinguish that. And then neurodegenerative diseases. This is why I think a movement disorder specialist is so key in the differential diagnosis because they can rule in and rule out some of these other neurodegenerative diseases. So that's quite a list of our differential diagnosis. And what is so tricky is that it's often more than one thing. So it's not always that it's just functional, but you may have functional movement disorder overlaid on top of Parkinson's, for example. That's a very common one. You might have it on top of MS or other things. So as a therapist, we have to sort through that because we may end up approaching treatment a little bit differently for that. Okay, so that is the common differential diagnosis. Let's just talk about a few of the tests that can be done in our examination. I talked about a few of these, 4 of them actually in detail in our Instagram live video, so you'll have to check that out. I talked about Hoover sign. There's a hip abductor sign, so resisting hip abduction on both sides. I talked about the drift without pronation, that the position of the face, so unilateral face pulling with the platysma, maybe jaw deviation. Sometimes there's a collapsing or give way weakness, but this can be really tricky because that can also happen with pain. So that's not, none of these tests, by the way, are like gold by themselves. It's a whole constellation of, of symptoms and testing. Another thing that I found really interesting, and this was also in the recent, there was a really great article that looked at functional stroke mimics. It just came out in 2020. This was one I hadn't thought of, but a inverse pyramidal pattern of weakness. What does that even mean? So typically, when we have somebody who has a stroke, the specific groups of muscles are a little more weak than others. So, for example, in the upper extremity post stroke, we might have flexors that are stronger than extensors in the upper extremity only, and the opposite in the lower extremity. So, what we might see in a functional disorder is the opposite of that. I find that really fascinating. So, these are all things that we can do to screen and test. We also can get a lot from our history. So, things that might indicate that there's more of a functional connectivity issue, a really abrupt onset, where it was like max symptoms right away, or an attack and reoccurrence. Now, remember, that might sound like multiple sclerosis too. So we've got to put that together with a lot more information, that waxing and waning. Maybe it changes with triggers, but remember, things like migraines can also be triggers. So we have to consider that in a differential diagnosis. The movement patterns change. They might be variable, they might migrate throughout the body. So these are all things within the history that may start to give us some clues, and we would put that together with our physical exam to start ruling in or ruling out a functional movement disorder. So, again, you'll have to catch our Instagram live video where I demonstrated and talked through four of those signs that I mentioned in the list above. And again, not one test, not one piece of the history is it. It's really the whole thing, the history, the timeline, all the clinical tests that paint the picture of the functional movement disorder. And again, the accurate diagnosis best done in the hands of a movement disorder specialist who can very clearly rule out some of these other things that can mimic a functional movement disorder and are very important to rule out. Okay, so we talked about the common differential diagnosis, how we might screen, test, talk about it in our history, and this how does this lead right into treatment? This is like what I love because one, by the way, great articles on this by John Stone, who actually talks about the assessment as the beginning of the treatment. Really love those articles. So one of the things that I love as we do some of these screens is that we can then explain what those mean. So one of my favorites is in the Hoover sign. So in the Hoover sign, we're asking somebody to attend their limb and try to meet resistance, kind of like our typical manual muscle test in a way. And when they're attending to that limb and full attention on it, they cannot activate it. However, when we attend to the other limb and have them activate the opposite muscle, so maybe the hip flexor instead of the hip extensor, we can feel that they can activate the hip extensor. So that is a positive sign showing that attention to the limb somehow creates a disconnect for them and they can't activate it, but we can unmask that activation through other means. And that shows us that there's the possibility that the connection is there, and we just have to find ways so that that automatic movement, that automatic activity is unmasked. That's what I think of in that particular task. We're unmasking some of their automatic activity, and then we build that into treatment. And it's really a great way to explain the nature of the disorder where there is an attentional piece that limits the brain talking to the body, right? And that we can restore that. That's a really good sign of good prognosis, too. So that's how within our testing, we can immediately start talking about the underlying connectivity issue and how we can help the reconnection. And in fact, we can show reconnection already happening and that we just need to really build on it. Really powerful, if you ask me. And again, I'll put a link into the neurosymptoms.org because John Stone and that group in the UK have put together some really great resources on that. But there you have it. We talked about common differential diagnosis, what we might do in our own testing and exam, and how that goes right into treatment and education and hope for recovery. Um, and that's just with functional movement disorders. So I told you at the beginning, differential diagnosis is my passion. It is the topic for our first fellowship course almost every year. And because it's so important in what we do, if we don't screen and understand what is happening, it's hard to treat. So, our first fellowship course is in January. We do our fellowship courses every year. There's 6 of them throughout the year. So I'll put a link here if you're interested in learning with us and diving deeper into the differential diagnosis and movement disorder. Um, I also, if you joined last week, you heard also that our Neuropracticity 3.0 course is out and it's $200 off until January 1st. So I'll put a link in there because you don't want to miss that at $200 off. That's so awesome. Mike Studer also told us last week that he was donating $100 to Resources for Hope with every person that signs up before January 1st. So I'll share both of those things with you because I think you would love to dive deeper with us on both of those topics to really help the people that you work with get better faster. And that's it. That's it for us for 2020. I'm so looking forward to 2021, taking the next 2 weeks to spend time with my family, get outside, do some hikes, be with the dogs, all of those great things. And I will catch you again in 2021. Thank you so much for joining us every week for these videos. I appreciate you. I appreciate the questions that you ask and your commitment to continuing to grow and learn. So thank you so much. And I will see you in 2021.